idea is by an intensivist. So we follow intensivists sometimes to give them credit, yeah? So what did this author recommended? This author recommended that there are 6 things for you to do, especially the first hour of sepsis. You have to deliver high flow oxygen, you have to take the blood culture, administer intravenous IV antibiotic, measure serum lactate, resuscitate the patient with fluid, and commence on accurate urine output. Alright? So suspect sepsis. Alright? The moment this diagnosis come out from your mouth, then blood culture needs to be done. Do you follow, like, for example, wait until fever spike, blood culture whenever temperature spike or total white rises? No, because these are very poor sensitive markers and specific markers for sepsis, especially in those older age group. They usually sometimes can just present to you with altered mental status, and hypotension might just be the only clues, yeah? So do you need to space out within 24 hours of blood culture? No, you don't. You can take one after another within 1 minute, alright? So you don't have to wait, now one, 24 hours later, another one, to enhance the detection that even if you take within 1 hour, it's the same as within 24 hours. And within 24 hours, I'm sure your patient must have landed somewhere, if not up there, right? Okay, and you must remember that the yield after antibiotic is not good at all. By giving antibiotic before you take culture, you will just ensure that 50% will be negative culture. Alright? So that's why the Sepsis International campaign recommended you to take blood culture as soon as possible before antibiotic delivery, so that Dr. Noraini here can do a better job. Okay? What about the volume of the blood? A lot of time we were told that, just take blood culture, don't know how much, housemen also don't know how much to take. Sometimes we take a bit, like, that tomato ketchup, syrup color. So, okay, I've done my blood culture. So, in order to ensure that your blood culture is going to be successful, you must at least take 20 to 30 mils actually. You know why? Because even though when a patient has bacteremic, the load, the number of organism is still very low in the blood. Alright? By taking 20 mils, the yield will be 38%, and 30 mils will increase to 63%. Every added mil will increase your positive finding by 3%. Alright? So if you can't get 30 mils, take as much as you can. Alright? Is that okay? Pediatric, of course, need a lower volume. I'm not going to touch on that. Now, is the numbers important? How many? 3, 4, 5, 6, 10? The more the better, right? Then Dr. Noraini will be saying that, oh, my blood culture bottle has finished. So, recommendation was given that you at least take only 2 sets of blood culture. Because by 2 sets of blood culture, the yield, if it's positive, it will be 99.3%. So the third will not added on another value, more value lah. Alright? Is that okay? Then, if you take 2 sets, then we are also able to diagnose those with catheter-related bloodstream infection, and they recommended only for you to send for aerobic culture. No need to do anaerobic culture. Is that so? Yeah, because apparently the sensitivity of anaerobic culture is not that great, and you only do so when you suspect that there is anaerobes infection. Yeah. So 2 different sides. If one you take from the catheter, then the other side you must take from the peripheral. And mind you, please label it for us. Because sometimes when the result comes back, all from patient. There's a remark there, all from patient. I know lah, all from patient where, right? Okay. So because we have been stressing this a lot for the past few slides, because sometimes we've been waiting for the blood culture, and suddenly it comes back as coagulous negative. Yeah. Wasting our time, right? Because coagulous negative usually means contamination. And contamination, sometimes a lot of us do not know how to differentiate. At the end of the day, the patient might just, end up with a prolonged stay. For example, if you have Bacillus cereus from the blood, likely it's contamination because these are, skin flora and all that, right? So what do you end up giving? Vancomycin. And how long do you give? 14 days. Just imagine, patient has already been there for sepsis 20 days. On top of that, you add on another 14 days, ended up with one whole month in the hospital, and everybody is shouting bed is not available. Alright, so these are the measures. I'm sure Farid is smiling up there. Now, how do you know that this is a true infection? Of course, when it's present more persistently in more than one culture, if you have all this bug, and especially candida. When the candida is in the blood, please always think that this is the actual organism, because candida will not be in your blood simply like that. Alright? And contamination, if you have only one positive blood culture and it flag up as Bacillus cereus or diphtheroids and all that. Having said that, sometimes it's not easy to make a decision. Alright? So that's the reason why we advocate to you to be very, very, cautious when you take blood culture. What about the time of delivery of antibiotic? Is it important? When you start antibiotic, the sepsis guideline recommended you to start as soon as possible, less than 1 hour. The reason behind this is because if you look at this graph, the time for survival from the first hour towards the end, just have a look at it. It's like kind of dropping trend, right? And the time for the concentration of antibiotic will take at least a while. So therefore, you must try to deliver your antibiotic as soon as possible. Again, another graph showing to you that by losing every hour, you are going to give rise to a 7.6% reduction in survival rate to your patient. That's the reason why they advocate that, delivering of antibiotic must be within 1 hour of patients being diagnosed as severe sepsis or septicemic shock. So what about empirical therapy? Having said, take your blood, having said that, you deliver antibiotic is easy, isn't it? Then somebody asks me, it's easy for you, but it's not easy for me. What are the empirical antibiotic that I should be delivering? Whether should you just see the culture result and follow the sensitivity? That's not it, right? That's usually targeted. By saying that empirical antibiotic means you take into consideration the source of sepsis, you take into consideration the microbiological organism, and make a wild guess, and hopefully you name it correctly. Alright? So that's what it means. It's easy to say, yeah, but it's not easy to deliver sometimes. So what does the guidelines say? So they recommended that initial empiric anti-infective therapy include one or more drugs that have activity against all likely pathogens and that penetrate in adequate concentration into the tissue presumed to be the source of sepsis. So they advocate for you to go as broad as you can for that source of sepsis, and then once the patient is stable, taper it down and de-escalate your antibiotic according to the tissue culture or the blood culture. That's what it says, and it gives a recommendation of grade 1B. Alright, so it's wrong. So at the end of the day, every time when you see a patient, a few considerations must always be made by you. What are the indications for antibiotic in this patient? The choice of antibiotic that you have, when to start and when to stop. So as I put it again, it's easy said than done, right? But what I'm going to do after this is just to bring you through a few case scenarios, very short. So this is what we see in medical. Another day, another same problem. 64-year-old lady who was previously healthy, seen at ED, history of fever, cough and dyspnea, lethargic, temperature at 38, BP lowish, heart rate 112, lung right lower zone cracks. Start antibiotic? Would you start antibiotic? Sharp? Yes, very good. I would. What's the likely source? Yeah? Pneumonia, right? Okay, what's the likely organism? Not sure. What's the antibiotic and what are some special consideration? Yeah, I don't think we need this, yeah, to diagnose a pneumonia in a patient. You don't need CRP, you don't need Procal, you don't need CT thorax even to diagnose pneumonia, yeah. So of course you will start antibiotic. Likely source is the lung. What are the likely organisms? Now I'm going just to point out to you, it's very simple actually. In community acquired pneumonia, the most commonest organism is strep pneumonia. But you go to outpatient, strep pneumo. You go to inpatient non-ICU, strep pneumo. You go to inpatient ICU, strep pneumo. So you're correct, strep pneumo, right? So what are the common antibiotic that can cover strep pneumo? Anti, alright? azithro maybe to cover your atypical. In a bit, more ill patient, then of course you may want to resort to ceftriaxone because in those inpatient ICU, there's always a chance of gram-negative bacilli here. So it makes sense, isn't it, why we advocate you to use augmentin and ceftriaxone in very ill patient in ICU. Alright, so this is a patient that we managed. We had the opportunity to manage as only skin deep. It's obviously cellulitis, right? 50 years old, Chinese lady, background history of diabetic, hypertension and hyperlipidemia, presented with history of fever with progressive left lower limb rashes and blister, and also pain for 3 days. She denies of any history of trauma, insect bite. It's associated with nausea, vomiting, and generally being unwell. See, I told you, ladies always have this unwell. You don't feel well. Then you are expected to settle their problem from this statement. So unfair, right? So BP of 80/50, heart rate tachycardic, temperature 37.5, and this is the left lower limb. Alright? So you can see a bit of rashes here. It's swollen, looks like cellulitis, right? But then having said that, is cellulitis as bad as this? Must be very severe, right? So within 2 hours, the orthopedic, the A&E then call you up. Hey doc, it's progressing. This is the time now. So what's going on? Alright? So of course the initial diagnosis could be left lower limb cellulitis, very bad, but then deep in your mind you always have to think of necrotizing fasciitis. And what are the common bug for necrotizing fasciitis? Again, the skin flora. What is that? Staph aureus, strep. And in those with diabetic and all that, of course you would have to cover a bit of Enterobacteriaceae and anaerobe. Hence, they recommended empirical therapy of ceftazidime, penicillin, and clindamycin or piclizole. Alright? So this will cover everything. So it's okay for you to go broad spectrum first. So your aim is to improve the survival rate of the patient. Later, when the ortho will help you to do some job care, you can obviously escalate your antibiotic once the patient is stable. Alright? So what is the special consideration that you would want to make in this patient? What else can you do to improve the survival rate other than the culture, the antibiotic? What else do you think? Is to go for source control. This is what happened. We asked the ortho team to have a look, and good of them. They go in, they debride the patient, alright, repeatedly, and at the end of the day, patient in ICU being intubated. After a month, patient woke out from the hospital. So source control, again, ladies and gentlemen, is very, very important, and it's been recommended as grade 1C in the international campaign, guideline, alright? So in those where there's abscess and there's all this necrotizing fasciitis and all that, so you must try and charm the ortho into helping you to source control the patient as well. Alright? Hertz doctor, 40-year-old lady, previously well and had history of fever, right hypochondriac pain associated with nausea and vomiting, temperature spike, BP lowish, lung heart clear, abdomen tender over the right hypochondriac, total white 15K. Start antibiotic? Yeah, obviously. So I don't have to continue my talk really, right? You get a message. Likely source? Yeah, very good. Intra-abdominal sepsis. God only knows what. Likely organism? What antibiotic? Alright? So start antibiotic, yes. Intra-abdominal sepsis. Likely organism, your gram-neck. In the tummy is always gram-neck and anaerobes. Alright? As simple as that. So what antibiotic should you give? Ceftriaxone and fentanyl. Alright? And special consideration, of course, similarly with necrotizing fasciitis, source control again is the next step that you want to charm the surgical team into helping you out with. Alright? If empirical therapy and all that is never easy, but we always have this guideline to back us up. Alright, just go to it and you will see what are the recommendations, and you can just simply deliver it. So in all ID talk, it's always never complete if you don't talk about this de-escalation antibiotic. So I'm going to take a bit of your time to share with you why we need to de-escalate antibiotic. And it's been recommended as grade 1B in the international guideline, but after the patient has been stable for at least 3 days and above. So once the culture is back, once the patient is stable, don't simply continue your meropenem. Please de-escalate. Alright? So why do we need to de-escalate? Because if you use broad spectrum antibiotic, you're going to kill all normal flora in the gut. And what are you going to end up with? This horrible bug here called Clostridium difficile. And this is going to give an impact to your patient. Patient is going to end up with diarrhea, fever again. You know, elderly patient goes into DVT as well. At the end of the day, patient might have to, go through 14 days of antibiotic. And if the 14 days of antibiotic is not working in certain center, they do fecal transplant. Alright? So this is the thing that why we need you to at least help us to de-escalate your antibiotic once the patient is stable. Now, if you feel that you have the upper hand on, compared to the organism, let me tell you and disillusion you here and now. Penicillin was invented in 1928, right? Everybody knows that. So we thought we were great then. But what did the bug give us back? Beta-lactamase enzyme, and rendered our penicillin, ineffective. Then we developed third generation cephalosporin. Smarter, isn't it? What did the bug give us back? ESBL in 1980s. Again, we are one step, behind. So we thought we are smart. We developed meropenem, merotapenem, and imipenem. But what did the bug give us? CRE in at least 2000, right? Year 2000. And we have to recycle our old poor polymyxin here. So in certain parts, polymyxin is also rendered helpless now. It developed resistance. So at the end of the day, what do we have here? Alright?